endometriosis and IUI and IVF, that is MAR. So let's uncomplicate. This is my favorite picture. I don't know why I show it again and again. I try to change a lot of pictures, but this is my favorite picture. And the uterus is not able to work properly. Uterus may be sad. It is unable to perform its duties. And then what we start putting some patches here and there. So how I decided I'll take this topic forward is that I thought that let's look at few common queries which you people ask. I thought about it. So I could focus on 11 questions which you people ask. The difficulty lies in the learning. It's not in the new ideas, but in escaping from old ones. So it's very difficult to leave the old ideas, what we have learned till now. Let's make an attempt. Let it go. We don't get, in our population, we don't get very bad endometriosis cases because we probably catch them young. And not many people come to us with pain. They come to us with infertility. This is what I am finding in our population. So there is not much of option for us to put a scope in all the patients. Though I always differ with a lot of laparoscopic surgeons, but the guidelines are very clear. We don't do scopy to diagnose endometriosis anymore. Does effect of IVF on endometriosis? Now we have known that endometriosis is driven by estradiol. So when we do IVF, does it lead to flaring up of the disease? Is it possible that once we give somebody drugs to increase we do COH or OI, will it make the disease become more fulminant? Do we have more recurrence? So not associated. Again, this point is killed for all my 570 students now, is killed. This question is done and dusted. IVF should be considered whenever we have an advanced severe endometriosis. IVF is the answer. Don't start doing for stage 3 and stage 4 IUIs, or don't start giving them letrozole or clinicians. I have had 3 pregnancies in my career in 20 years in IVF, pure IVF. I have got 3 pregnancies in stage 4, and they were spontaneous, in which I said nothing can be done. Frozen pelvis, they have conceived. So God can do the wonders, but you don't wait for such wonders. IVF is the right method for stage 3 and stage 4. Burning issue 3. This is one continuously people ask: Dynogest, Ureprestol. I think they should not be used at all. There is no place of using these drugs at all. When they want fertility, use it in case they want pain management or quality of life. But fertility, these things have got no role at all. Scratch these drugs off. Scratch for fertility. Our experience, no need if early ART is required. Burning issue number 4. Should we carry out MAR? What is MAR? MAR is IUI, MAR is IVF. Medically assisted reproduction, starting from giving them a clomiphene, giving them a letrozole, doing their IUI, doing their IVF, everything is medically assisted reproduction. It's called MAR. Any doubts about MAR, anyone? A lot of time you ask me in the class, what is MAR? I hope it's clear now. IUI and endometriosis, suppose the tubes are open. And we have done, and we don't even know that this patient has got endometriosis. Half of them we don't even know. 10% of them have this problem. We don't even know. So HSCs we are doing for the patient. All mild, moderate we are doing, and HSCs for all. So I've never found any patient going into severe exacerbation with endometriosis. I've never found. Maybe one odd, I don't remember. So when you have to do ovulation induction, just remember that whenever we have a known case of mild to moderate endometriosis, even sometimes stage 3 endometriosis, don't carry out expectant management. Expectant management nahi karna hai. Don't do it. Give them clomiphene, give them letrozole, and add HMG and do IUI. So there is no role of doing expectant management, number 1. IUI is the right method, and IUI with controlled ovarian hyperstimulation. Is this clear? Anyone having any doubt here? I'm pausing here. I'd like to hear from you. Anyone having any doubt here? No one is talking.
No, sir.
No, very fantastic. So it's really fantastic. This means that in endometriosis, we have to always carry out 𝐄H plus IUI. So this point is done. Okay, I want you to read this. I want you to spend some time, all of you, spend some time, and I want you to read this picture. Take your time. What I've written here is a पढ़ लीजिएगा. Have you read?
Yes, sir.
Good. Fantastic. Fantastic. The live birth rate is 5.6 times more. It's more when we are doing IUI and 𝐶OH. My experience has got a good fertility potential. I normally do more of IVF than IUIs, but yes, it works pretty well. Burning issue number 5. When do you move these patients to IVF? IUI we have done. We have done whatever we could do. When do we take them from IUI to IVF, or what is the time when we move them towards IVF is my query. And let's see. When we have a tubal factor, obviously when tubes are bad, we do it. Male infertility, we do it. Failed IUI in minimal to mild endometriosis, we do it. Failed IUI in moderate to severe endometriosis. I told you, even severe endometriosis, we can do IUI. There is nothing wrong in doing an IUI for severe endometriosis. When the tubes are open, do it. Moderate to severe endometriosis, we can actually try, but thoda sa we have to be slightly careful at this point of time beyond 35 years. So moving ahead, primary IVF should be suggested if during the laparoscopy severe endometriosis is found compromising the tubal function. Now this is, we only operate on these people when they have got endometrioma. Just remember that endometrioma we all diagnose, but deep infiltrating endometriosis is not easy to diagnose by us. Though we look at uterosacral thickening, we look at pelvic inflammatory disease, we look at hydrosalpinx, but endometrioma is the one which will lead us towards doing a laparoscopy in case required. Otherwise, we don't even know. After we have done cystectomy, if no conception, even after superovulation and IUI for 3 cycles, meaning that in case somebody's got an endometrioma and you have removed her endometrial cyst, chocolate cyst, and she's, after 3 to 4 cycles, she's not able to ovulate. So it's not important that after we have removed the endometrioma, it's not essential that we move her to IVF directly. It is not important. I mean, we can give them a trial with IUI also. But in case 3 cycles they don't work out, at Birla Fertility we normally give 2. At BFI we give 2 and then we move them to IVF. That's the right way to manage. Don't be in a hurry. In case the male factor is fine, AMH is fine, don't take them to IVF straight away. Our experience is this. I want you to read this. Take your time. This should be your take-home message from me. Just read this once, and then I will go to the next question. Okay. Great.
So how
So,
much is the duration
yes, ma'am.
of this expected management? How much time should we wait for this?
I always say that there is nothing called expected management time period. You see, you look at the couple. In case you prefer that a couple is staying together and they are intelligent, tubes are open, sperm count is okay, you can tell them to be together for 2-3 cycles, not more than that. I normally give them around 3 to 4 months, not more than that. But in case AMH is fine, sperm count is fine. But as early as possible, I like to shift them to 𝐶OH and IUI.
So, what is the preferred drug for 𝐶OH, letrozole or gonadotropins?
Both, beta. Richa, both. Sorry, Richa, both. I told you, Letros plus HMG. Use both.
Sir, how many cycles we can do for IUI?
Maximum 2 to 3.
Maximum. Thank you, sir.
Okay. Burning issue 6. ये वाला लड़ाई वाला सवाल है. Here I have a fight with everyone. Here I would like to invite any of the laparoscopic surgeons who are here. In case Sumita is here, Sumita is always with us in all the classes. In case Sumita is here from Lucknow, she can take this query, or anyone who's doing laparoscopy can take this query. Anyone would like to comment? Laparoscopy for all before ART.
So I agree to it.
For all? Who said that?
No, sir. Ramit.
Ramit. Where Ramit kahan hai? Ramit is also a laparoscopic surgeon. Where
I
is
said
Ramit?
no, sir. Not for all.
Not for all. Okay, fine. So you are with, so Ramit, you are with me. You are with me, no?
Yes, sir.
Yes, fine. Anybody else? Any laparoscopic? Anyone can. Yeah, Dr. Akila.
Not needed for all, sir.
Wow, great. Anybody else? Anybody else?
Laparoscopy actually a good 3D IU and 3D ultrasound. You actually don't need a laparoscopy in all. In mild to moderate, you definitely have not to use, unless and until you think that this is going to affect your oocyte pickup. Only then you have to.
Who said that? Who answered it so beautifully? Summed it up so beautifully?
Dr. Geeta Khanna from Lucknow.
अरे गीता मैम, आपको कैसे मिस कर रहा हूँ मैं? दिख ही नहीं रहे मेरे को, किधर हो आप? Okay, hi Dr.
Unless and until it is going to affect your oocyte pickup, you need not go for a laparoscopy.
Perfect. Actually, perfect. I had gone to page 3-4 to look at you. You're on page 1. Oh, great. So when I was in the army, I'll give you an example. I've got a very different sort of a career profile. I've spent around 30 years in Indian Army. And out of this, 20 years I've done IVF. And the government is the biggest unit in the country. First ones to start IVF in the country, the government was Indian Army, free IVF. So our listing for laparoscopy was going for 2 to 3 months. After doing 100 laparoscopies on average per month. It was around 100 laparoscopies and 200 hysteroscopies we were doing every month. So every OT, DHL, hysteroscopy. I stopped it completely with my team. If somebody is from army team here, they can say hello. They will agree with me. I don't know. So we stopped completely in 2014-15 after the ASHRAE guidelines. We have not touched laparoscope thereafter. We don't do hysteroscopy thereafter. We don't do. It has to have an indication. With 3D coming and helping us, it's really helping us quite a lot. So what we found is that our results have actually gone up, not come down. Very quickly we can treat patients. Otherwise, waiting period for laparoscopy, then admissions, discharges, and multiple things happen. So laparoscopy has got, I won't say no indication, but as Dr. Geeta, Dr. Ramit, everyone summed up, I think it's a right method of not doing it at the first go.
And you save a lot on patient's pocket.
Exactly, ma'am. Exactly, ma'am. And good coming from a leading gynecologist of the North India. You are giving a message to lose your money, but I think I'm totally with you, ma'am. That's the right answer you have given, and so nice that it came from a leading private practitioner. Great.
Thank you, sir. Thank you.
Anybody from Indian Army here with me? They can also talk about their experience. We do large numbers in Army.
Good morning, sir. This is Nagraj, sir.
Hi, you are here, Nagraj? Okay, good.
Yes, sir.
Somebody is always. Nagraj, what is your opinion? Can you tell the people your opinion? Can you put on your cameras? Where are you? Where are you?
Sir, as you said, we have really transformed from laparoscopy era to ultrasound era, sir.
But where are you? I can't see you. Where are you? Let me see you. Okay, yes. Yes, Nagraj.
Sir, yes, sir. We are with you, sir. Now we have changed over, sir. We are not doing laparoscopies, not for all, sir. Very selective.
Selective. Great. Thank you so much. Did you find any change in transition from 2014 till date? Did you lose pregnancies? You know, did the
No,
number
sir.
go down?
No, pregnancies have not gone down, sir. In fact, treatment has become fast and early, sir.
Fantastic.
And patients are happy, sir.
Very good, very good, very good, very good. Great. Thank you so much. In fact, you don't किसी नागराज को जानते नहीं होंगे सब लोग. He's I think one of the senior most guys in the Indian Army now, doing IVF from past 10 years. He would have done around more than 10,000 pickups. Big experience. Thanks. Okay. Burning issues.
Thank you, sir.
Thank you, brother.
Sir?
Thank you, brother. Yes.
Sir, I wanted to ask, is there any specific day in the menstrual cycle when this 3D TVS could be done, or any day?
Okay, very good question again. So, see, remember one thing that for getting the 3D ultrasound, we do 3D. In case you were there for a curtain raiser on, I had a curtain raiser on this topic. So remember that 3D should only be done. 3D can be done anytime. See, 3D can be done anytime. But what is the right time to do 3D? See, you can say that you want to have a nice biryani and lot of good food. What is the right time? Is it dinner? So you can afford taken food anytime. You can food anytime, but the right time is at dinner. So whenever we have an LH surge coming in the body, when there is an LH surge coming up, about which we had spoken for 2 hours before one day, one of the curtain raisers. Sandhya, do you remember? No, you don't remember. You were there on that class. We had a big curtain raiser on this. When LH goes high, along with the LH going high, before follicle ruptures, there is a premature surge of progesterones. Premature progesterone, we call it PMP. When PMP and LH comes together, they will act upon the uterine arteries and the spiral arteries. And what do? The moment it happens, it will drastically drop two things, RI and PI of uterine arteries and spiral arteries. So that's the time zoning of the blood flow is done. So whenever we do any ultrasound for 3D, it's got two meanings. The 3D will cost you around rupees 4,000 to 5,000. And normally 3D is best effective when you do it along with color Doppler studies also. So I say when the follicle is touching around 18 millimeter or 19 millimeter, that's the time I expect estradiol is around 250 picograms. When E2 is 250 to 300 picograms, I assume LH surge is now coming. Normally in a woman. Am I right, Dr. Geeta? You are shaking your head. ठीक है ना, ma'am? The simple logic in normal cycle. So that's the time when we should do color Doppler and 3D together. The right day will be not day 8 or day 9. It will be the day when everything is in the order. And what is that day? Follicle 20 millimeter or 18 millimeter and good follicle. That's the time E2 is around 300. That time you do it. Well, that would be my answer for your query.
Okay, sir. Thank you.
Okay, great. Keep asking without hesitation as we are moving ahead. Now, burning issues for all. Yeah. So I think I wanted to have a debate, but Dr. Ramit and just drop me down. She said she agrees.
By that time, the endometrium will be there. We can also find the junctional zone.
Exactly. Very right. Great.
We want to assess the endometrium and the follicles, and we can come to know what is the ovarian. See how much the endometrioma is pressing the follicles. We can come to know that also. Perfect answer. Thank you so much.
Hello. Yes, sir.
Hanji.
Laparoscopy for endometriosis before ERT. So, is it, when and how we can decide that it should be for adenomyosis also?
See, adenomyosis, you never do laparoscopy. It is hysteroscopy diagnosis. It is ultrasound diagnosis.
Myomectomy.
नहीं, अभी मैं कुछ और बोल रहा हूँ अभी इस सवाल का. This question says, should we do laparoscopy for all before ART to diagnose endometriosis? No. You're talking about when you've diagnosed it.
Yeah.
That's the next question. See, we all are in a habit of doing laparoscopy for all. We all are in a habit of doing a hysteroscopy for all and bill the patient 1 lakh rupees. This is what is it right or wrong? Which let's find an answer. Looking at the Canadian guidelines. Canadian guidelines say that Just don't read between the lines. I don't recommend reading between the lines. The efficacy is that only one additional pregnancy will occur in case we do 8 cases. 8 case karke we get benefit in 1. So it is a recommendation 2. So they say that it is controversial. So they say that HSG is good enough. Normal sperm count, HSG is good enough for any woman who's coming to us. Even if she's having minimal to mild endometriosis that goes undiagnosed, we really can't do much. But in case we do 8 cases, we will get 1 pregnancy. That's Canadian guidelines. Need to treat. I always tell you people some information that's called NTT. NTT is 1 additional pregnancy for 8 procedures. Coming to the ASRM guidelines. Level 1 evidence I'm giving you from this thing. How beautifully, look at it, how beautifully they say that for every 12 patient having stage 1 and 2 endometriosis, every 12 patients, in case you do, for every 12 patients having stage 1 and 2 endometriosis, in case we do these surgery, there will be 1 additional pregnancy. And not all of them are diagnosed with endometriosis. So to get 1 additional pregnancy, we need to do 40 cases. 40 cases of laparoscopy. A huge number. And so in net, minimal number of laparoscopies required are 12 to get 1 pregnancy. And as per the Canadian guidelines, 8 procedures. Here I am telling you not to do it. Not do. This has been recommended by all of you 5 minutes back. You have all spoken. So it's not to be done. Coming to NICE guidelines. They say when you put a scope and you find there's a problem, do it. You should do it, but it should be done with a purpose. Don't do laparoscopy which is diagnostic. Do laparoscopy which is operative, and then you fulgurate or you excise, whatever you want to do. I won't talk about this today. That's in part 2 of the lecture. So incident finding, treat, but don't try to localize endometriosis. That is not right. They say whenever we do a laparoscopy, operate as per NICE, agreed. But in case to diagnose, we should not be doing incidental finding, treat. Coming to the ASHRAE 13, what do they say? They say need to treat 1 in 25. 25 case करेंगे तो 1 pregnancy मिलेगा. Imagine 25 laparoscopies has been done. The huge number. So that should not be done. So our policies, as Colonel Nagaraj brought out and Dr. Geeta and everyone spoke, Dr. Remy spoke, is that we are not doing laparoscopies for diagnosis. It's only operative. But here, one thing is for sure, your ultrasound should be a magical ultrasound. So we use a lot of 3Ds, we do a lot of color Dopplers, we have good, no adenomyosis can miss our eye. So you should be so good. I'm very, very sure that with 8 to 9 hours of training in ultrasound, my team members, I call them ICTians, they'll never miss an adenomyosis. So course 2 and course 3, it'll be impossible for you to miss any adenomyosis. And if you miss adenomyosis, then I think it won't be good. We've covered it so well. Role of ultrasound guided endometrioma aspiration pre-IVF. So we have an endometrioma. Do we want to aspirate it? So simple answer will be, answer is debatable, but I will say there is no role. You gave me so many questions. I've written all your queries down today. I've written all the queries. I had 3 questions upon size of the endometrioma. Remember that no role of surgery. The problems can be that they can have leakages, they can have adhesions, they can have ovarian abscess. Sometimes we have to undergo oophorectomy. Debatable. These are the debatable things. But there is no role of doing endometrioma aspiration pre-IVF. Aspirate nahi karna hai. When I started my career in 2003 in IVF, that time my surgery was only one, that was endometrioma aspiration. So my teacher will give me the needle in the end, and they always had 4 to 5 cases of endometrioma. In Indian Army, we had a big load of patients. So every OTL aspirate 2-3 endometriomas. So that was my OT list on my name. So nowadays, endometrioma aspiration can have multiple problems. Don't do it. Can someone tell me the role of endometrioma aspiration pre-IVF? Is there any role?
No, sir.
No. No role. That's not the right answer.
So in case there is a ovum pickup to be done, that time if the endometrioma is proximal to the follicles which are going to aspirate, that time we may have to do it and then change the media, flush it, and then again do the rest of the pickup.
100% right answer. So no problem. I mean, we should keep talking. The aim of these classes is that we should keep talking. Baat karte rahe. That's very important. I'm going to take around 5-7 minutes more, 8 minutes more. Then I'm going to let you go for your morning chana bhaturas. Burning issue 8. Endometrioma role of surgery. We've gone through multiple guidelines. More than 3 centimeter, operate. More than 3 centimeter, operate. These are the Canadian guidelines. American guidelines, they say more than 4 centimeter, remove. Even smaller, when they come in the way, remove. Then the guidelines from NICE, they say do cystectomy. They recommend. Again, NICE, more than 3 centimeter, you remove. ASHRAE, not recommended. Until they're coming in the way of the needle, don't do it. When you don't do it, that's a better option. And while doing it, also give antibiotic prophylaxis. Antibiotic prophylaxis can be given. So the moment it is being done, after we have done the endometrium aspiration, now don't put them on GnRH analogs. Try to stimulate them right away. That's the answer which I want to give you. So looking at this, we have to restore the normal anatomical relationship, reduction of pain, accessibility of follicles after the OP is important, and improvement of reproductive outcome is important. So in case you want to do a surgery, it should not be ablation. Don't use a cautery. Some people say, I use monopolar cautery, bipolar cautery, I do this, I do laser. Please don't do it. In case you really want to help this person, do cystectomy, and this should be done with suturing. Otherwise, your AMH is gonna fall down. Use more of sutures, fine sutures. You can use cautery in case required, but there's a minimal superficial cautery can be done. So, in case you do endometrioma surgery, these are the risks. And
shall I add, sir, here?
Yes, bolo na.
So actually, when we are doing the cystectomy, now the concept of modified cystectomy, where you can remove, peel out the cystic wall, which is easily come out, and add the hilum where the antral follicles are gathered. You just leave the piece of cystic wall so that the ovarian reserve will be preserved to some extent.
Yeah, no, actually, the whole ovary has got ovarian cortex, 1 millimeter. Follicles are everywhere. They are more near the hilum, agreed, but they are everywhere. So peeling off is the right answer. Peeling is the right answer. I totally agree with you. Do peeling, but wherever you have a bleeding, no, use a fine suture and stop bleeding. This will be the final message. You're right. I agree with you. But you must be aware that we shouldn't be opening endometriomas like when we were young, one surgery which was given to us very, very freely was PCO drilling. So any patient coming, drilling tum kar lo, as a junior doctor, junior gynecologist. So what do you say about PCO drilling? Any one of you? Answer.
Yes, sir. I'm doing at times. I'm doing at times, sir.
You're doing, Ramit? Yeah,
Not responding.
Yeah.
Not advised.
So can you
At
give me
times I do.
the indications of doing ovarian?
So when the LH level is more than 10 and
Yes.
AMH is subsequently high,
Okay.
and the patient is not responding to gonadotropins at that time, and patient doesn't want to go for IVF.
Okay. ये क्या
Hello.
लिखा हुआ है? Is it written somewhere? LH
For
of 10?
LH,
10 कहीं
yes,
है
so it's
क्या?
mentioned. Yes, it's
अच्छा,
mentioned.
then
LH highly raised,
okay. Then I'm
and
sorry.
AMH also.
AMH I know,
And
but
the
LH 10. No, fine.
ovarian volume should also be more than 10.
No, perfectly fine. LH 10 I didn't know. But once you say it has to be there, I'm sure. I'm knowing you.
All polycystic ovaries are not supposed to drill, sir. When we put the laparoscope, when you see that the ovaries are too bulky, and in some situations, a few punctures can be recommended, but as such, it's again a controversy that.
So there is a method to calculate the number of puncture also. There's a method to calculate.
Correct.
According to the volume.
Correct. So basically, we have to be mature enough to do it. We have to mature enough to do it.
Another thing, sir. Then we'll puncture the ovaries.
So debate is on. अभी मेरा काम खत्म हो गया. अभी आपस में बात करेंगे. I can have my water. Yes.
No rule at all. With a beautiful freeze-all policy in PCO ovaries or in a hyperstimulated ovum, you can actually, you need actually no drilling.
No drilling.
So
when the PCOS patients are not
in very
responding to clomiphene, then ovarian threading is substitute for the GnRH, adding the GnRH.
Yes.
Gonadotropin.
Yes. Correct. I agree. But a lot of debate is here. I think I'll call Neeti. Neeti, you can sum it up. Is Neeti around? Neeti is not around.
Again, for drilling, sir, when we can catch the ovaries easily at the infundibulopelvic or uterovarian ligament, that will be become more easier to catch the ovary. But ideally, one should not supposed to drill at those two places.
Correct. Avoid करना चाहिए. I agree.
Yeah.
You should avoid. I think I can. हमें तो सब senior most कौन दिख रहा है मेरे को? Dr. Liza Chaudhary. I think she's the senior most here in this group. Dr. Liza, are you there? We can take her opinion.
Yeah.
What do you feel, ma'am? With your experience, you got around 30 years in IVF. Whole Bangladesh you have treated.
I think you are very correct. We give when there is resistance, that is letrozole, clomiphene, even gonadotropin resistant, then we do PCO drilling.
Resistant.
But actually we do right and left, but nowadays we are not. After starting ART, we are very restricted about PCO drilling.
Great. I think you have summed it up so well. In case you do, then you must follow the guidelines what Dr. Amit brought out. We have to be careful. There are indications, but less indications. Fine. Our policy, no surgical intervention. Intervene if patient is symptomatic or ovarian accessibility is affected. That's the only indication we have. Burning issue 11. I'm running short of time. For Sandhya cuts me down. Burning issue number 9 is pre-treatment before ART. Should we give somebody analogs or anything before we do the treatment? Look at if the patient is known to be having endometriosis, suppression with 3 to 6 months with add-back. Just suppression is good enough for that patient, I personally feel. And medical management is not indicated. You can do suppress. We can do suppress, but the aim is that suppression should be towards pickup. Towards pickup and not just suppressing it for taking her pain away. So then we must immediately shift to IVF after the suppression phase is over, of 2 to 3 months. I normally give it for 2 months, but books have written 3 to 6 months also.
So when you give GnRH analog, so what do you suggest, giving monthly treatment, or now we have a 3-month depot preparation available? Do you suggest to give that?
You're talking about 10.6 Zolodex की बात कर रहे हैं ना?
11.25, yes sir.
हाँ 10.6 की बात कर रहे हैं ना? 10.6 है ना? बड़ा वाला. 11.25, 10.6. What we are doing is we are giving the patient 3.6 or 3.75. This is This is one of the brands I use, and I give them 2 shots. I don't give 3 months.
Okay.
I don't. That's for prostate, and it can be given here also. But I don't wait so longer. After the surgery has been done, I quickly give 2 shots and go ahead. Okay. So you can give, but for the audience, your answer is correct. It can be given. It can be given. 11.25 is recommended. So but normally I give. It can be given, but I only give it for 2 months.
Okay. So just one more question I want to ask. Like sometimes there is an adenomyoma which is impinging on the endometrium, and when we do hysteroscopy, we realize there is a bulge as well.
Big problem.
Those adenomyomas, should we remove or just put Mirena and then follow it?
Mirena. Jate nahi adenomyoma. I have not seen people removing adenomyomas very well. And whatever they have been removed until it's done by, I think, few people can do it. Few top guys. I named one doctor from Delhi, Alka. Dr. Alka is very good in this. I don't know that many people can get a good outcome in adenomyosis.
What is your opinion? One should go for adenomyomectomy or not?
See, it all depends upon the patient, but I feel that we should go. We should go in for adenomyosis treatment. We should go. And then Mirena is there also. They take out the adenomyoma and put a Mirena. And the patient can afford, spend rupees 1 lakh or 1.5 lakh rupees, undergo myomectomy, followed by Mirena. Mirena is going to suppress, and then you carry out her FET.
And another thing, sir, when one goes for adenomyomectomy, the whole wall is affected. We are doing partial surgery, not complete.
Yes. So yes.
How will you discuss?
I don't have any answer. I always say that majority of my patients have undergone surrogacy for this.
So for how long Mirena is to be kept?
3 months. 3 months.
Okay, thank you.
This much I know. But I've never done adenomyoma surgery in sense. Whenever the young gynecologist 15 years back, 18 years back, in fact, when I left all these things, I was doing a lot of adenomyomectomies. I had no idea what I'm doing. But now I don't touch adenomyosis.
So when the adenomyosis is localized, in those cases, it gives good results. When it is entire, like it is generalized and it is global, in those cases, it doesn't give good results, because I've got results with localized adenomyosis.
So you can talk about them. Ramit, hai na? Ramit bol rahe hai na?
Yeah, yes, sir.
You can tell people about your experience. You can talk about your experience, Ramit. मैं करता नहीं हूँ this surgery. I don't do this surgery.
So I did 3 surgeries and localized. I got good results. The patient conceived. Even I did hysteroscopy after 3 months. Then I induced the patient. I got results with it.
Fantastic, fantastic. So that's what I'm saying, that there are laparoscopic surgeons. They can talk better than me. But
is the big problem in these cases.
The role of agonist in adenomyoma.
Very good role, very big role. You can give 3 to 6 months or 2-3 months. You can try it out. I do this. These things I'm doing, but surgery I've got no experience. So I said, okay, there are more educated people. They can talk about surgeries. Surgery from my side doesn't work that well. I've tried, it didn't work, so I left it. Okay. So, but you need to be expert. I'm not expert in adenomyoma surgeries. So but overall it doesn't work out that well also. Okay. So this is the therapy. Yes.
So one thing I would like to know again. So pre-treatment in endometriosis cases is you are doing with the Lupride, Agon?
Yeah, Lupride or Decapeptyl, whatever you want to use, Zolodex, you use Gosarelin, whatever you want to use.
Prior to stimulation.
Yeah, after stimulation.
Okay.
Okay. So
Decapeptyl, sir, how will you use? Dose, Decapeptyl?
No, you can use 3.6, 3.75, or you can use 11.25, whichever brand you are using.
Monthly doses.
Monthly dose.
So if you give GnRH analogs before ovum pickup, and if you freeze the embryos, then you give GnRH analog before the embryo transfer?
Yeah, you have to give. LH high रहता है ना इनमें. LH high रहता है. So always from day 21, we just got I think 2 pregnancies back to back. I had to cancel their case minimum 3 to 4 times. VIP patients. I had to cancel their case. They were very angry, shouting at me. But now they are pregnant. And their embryos are frozen 5 years back. One of them. So it took me around 4 cancellations before I could get it. Every time I'll find LH will go very high. E2 will be very high on day 2. I kept cancelling. I finally drew a balance, and now she's pregnant at I think she's at 9 weeks twins. It's a challenge. We have few successes about which we talk about, but large number of them are failures also. but successes do come in case you do them tactfully. Okay, so don't offer them any pre-treatment. This is important before ART until you want to do an IVF.
I want to have a question.
Yes, please come. Please answer. Davis.
So when you do the down regulation before the stimulation, do you go ahead and transfer in that same cycle, or you freeze and then down regulate again and then prepare for an FET?
So what we do is, Dr. Rumba Davis, who's speaking? Can I know your name? Who spoke?
Davis Rujumba
Davis
from Uganda.
Hi, how are you? How are you? How are you?
I'm okay.
Very early. What is the time in your country? 5:30 or 6 a.m.?
7:20.
7:20. Okay. We are at 10:30 now. Okay. So what happens is that we have to always down regulate with depots, carry out their cycle and freeze their embryos. Then we freeze. And after we have frozen, after 2 months or after 1 month, we start again. At that time, we down regulate with daily injections of leupride or decapeptyl 0.1 or 0.5. And then we keep the down regulation on till the day we start our progesterones. And then we do the embryo transfer. There are 2 different cycles. For FET also, we down regulate.
So,
okay.
I have a question.
Yes, Navjit. Can you put your cameras while you're talking? If you can put your camera, that'll be nice. We can see each other. Yes, Dr. Navjot.
If we downregulate the patient before stimulation, before controlled ovarian hyperstimulation, will it not lead to increased dose of gonadotrophins?
It would definitely, Navjot. So there are 2 ways. There are 2 ways we can do them directly. We can also carry out something called a sandwich protocol, what we call it very commonly. So you downregulate, do E2LH, and then start NTAG.
Yes.
But in NTAG, you can give a gonist trigger. There are a large number of PCO patients who have got endometriosis. So normally we think that endometriosis means low AMH. Because so many commonly we get AMH of around 5, 6, 4 in the PCO patients also, in endometriosis patients also. So always be very careful about ovarian hyperstimulation.
So yes, sir. One confusion, sir. You said when we start progesterone till that time daily we used to give decapeptyl. So from day 1st, 2nd of cycle, you are giving till progesterone?
No, what I do is very simple. I got a very simple method. Day 3, day 4, I give them a depot.
Yes, sir.
There's no pregnancy. Rule out pregnancy first. Do their beta HCG, because many times you get surprises many times. So do their beta HCG. Start there, or a UPT, the way you want to do it. Don't trust ultrasound for early pregnancy. You may get into I've been into problems. And give them a depot. And on the you after exactly 1 month repeat that depot. When you give them a depot, tell them that they will have flare-up bleeding after the depot. 4 to 5 days after the depot, they'll have some bleeding, that is common. And after giving 1 depot, 2nd depot on the day of starting 1 month prior. After 1 month, you give a 2nd depot. And from 2nd depot, 21st day onwards, I start with a daily dose, short acting. That's what I do. Then I follow a typical long protocol. Okay. In case you feel comfortable, E2LH is fine. You can convert it into an NTAG protocol also. Okay. Well, perfect. So now I'm ending towards my talk because I have taken more of your time. Before people start leaving, I'll just finish it off. The management is not effective with all these things, and we have to be careful. And 3 to 6 months we can give, and it will improve the clinical pregnancy rate in endometriosis. Okay, just so you know, our policy, not routine. I don't do in all. I don't give any hormonal intervention. In case there is infertility and this sort of a problem, I give it for 2 months, and we call it a long protocol where we give 2 shots. This is what I do. Burning issue, last one. GnRH treatment or surgery before ART. Now you remove the endometrioma. Would you still like to give her any suppression and do her IVF later? No. Or you would start earlier? So answer is very, very clear. Canadian guidelines says that no evidence. We should do it immediately. Don't suppress. Not recommended. ASRM says controversial. They say that it may help in severe endometriosis. Then NICE guidelines say the same thing, or not recommended, it doesn't improve the pregnancy rate. And then again for NICE, not recommended. ASHRAE says not recommended. So we don't give any drugs thereafter. Our policy not offered. Take home message, role of IUI in mild to moderate disease, role of antag versus agonist, I leave it on ASHRAE 2021. They're coming out with some guidelines. I'll send you a copy. Clomifene versus letrozole, I don't have any answer. I prefer letrozole for all the cases now. For OI. Role of OC pill damages, no role actually. No role now for infertility. Role of surgery, no role. Limited to non-IVF indications only. When you have pain or something, do it. Role of long-acting GnRH suppression, becoming debatable with time. Wait for ASHRAE guidelines. They may spring a surprise 2021. Endometrioma, leave them alone, don't take them out. Medical management, not recommended. Routine diagnostic laparoscopy, not recommended. If surgery indicated, cystectomy. ASHRAE guidelines 2021 is a draft. Is there any MRCOG with us today? In case there is, yeah, Dr. Suman was there. Any MRCOG there, they may have the new version of this. But I've got a draft version of this. So these are the things. These are the treatment of endometriosis associated infertility. I'll be sending you this. You can read them. Basically, read chapter 3. Read chapter 3 from this. I'll be sending you it very quickly. And they have got a large number of recommendations. Huge recommendations with infertility they have given. Generally, they are the same ones. They're not much of a difference. Whatever they have said, we have already spoken. But there was something I wanted to share with you. Read 59 and share in our groups. No, when you read this, you can read para 59 and then you can start a discussion. I think Dr. Akriti will be back in 4 or 5 days. She has gone to UK to get her MRCOG degree. Then she'll be initiating ASHRAE 2021. I've told her. We'll be back by this, I think, weekend. Then sector 56. So I wanted to read 56 and 59. Both are debatable, and then I think we will take it on in our classes when we meet again. So this is it from my side. Thank you so much. I have overshot my time. I'm sorry for this, and I'll stop sharing now. I'm here in front of you. We can take few questions.
So you said for stage 1 and stage 2, we should not do. You said not to do laparoscopy, no, sir. So how did I stage 1 and 2 endometriosis?
Because they are not diagnosed. They're not diagnosed. They're not diagnosed. That's what I'm saying. They are not diagnosed only, because to diagnose them, we diagnose 25 cases. We do 25 cases, we'll get findings in few cases only, or 10 cases, we get findings in few cases only. So it is not recommended. So stage 1, stage 2, how do we make out? There's no way to find out. Until patient is symptomatic, then you can do it. But an asymptomatic patient, don't put a laparoscope. But in case you do a laparoscopy and you find a problem there, then you should always intervene.
Okay, sir. Okay, thank you.
Yes.
So one thing, it was discussed in between. When we do OPU, we have to aspirate endometrioma.
Never aspirate endometrioma.
So one thing it happened with me, there was a case of ovarian abscess after pickup. So how can we prevent it? It was very
you give antibiotics. With endometrioma, I'm very scared. I normally give minimum 3 antibiotics, 3 doses. I always say. I'm scared of endometriosis because one flare up and she'll be in ICU for 3 days. And ICU is not a problem. You'll always think about that there is a gut injury or bowel perforation. They'll come like bowel perforation. They'll go into peritonitis, peristalsis, and we are head. I'm very scared of that. So because it will mimic bowel perforation. To open, not to open, what to do, we're very scared.
Sir, good morning, sir. Sir, what to do for if the LH is day 2 LH is very high?
Aarti,
if we give,
Aarti, I get your point. You got a very, very right question. This is my main challenge all the time. Aarti, what I do is that I down-regulate them. I've failed a couple of times in the patient, but now I've become a bit smarter, I feel. I don't know how smart. I give them down-regulation with a depot only. When it is not, yeah, I give a depot down day 5.
Flare effect will not be there.
नहीं क्या करना है आरती, day 5 पे ना डिपो लगा दो, day 5 पे, day 2 पे डिपो लगा दो, and day 21 I start giving them daily dose.
Daily dose of
Lopride or decapeptyl. Along with this, I give them a OC pill. She will bleed. So when she bleeds, after 2-3 days, continue her on depot on daily dose, then do her E2LH. E2LH will normally come down. With this thing, E2LH will come down, and then you can carry out the FET. This problem I'm facing at my place also. You're right.
Sir, pre-ART suppressive therapy you said, no, sir, with 2 months of GnRH agonist.
Yeah.
So how to give that, sir? On day 2, we give 3.75 mg of leuprolide.
Day 2, day 3, day 5, after ruling out pregnancy, you give. Rule out pregnancy. This is important. Don't end up with a pregnant woman in which you have down-regulated. You see, you don't know how the woman will behave. So be very careful. Just do a beta HCG and do it. Then you're safe. Okay.
And second dose 1 month after that we give, sir?
Yeah, exactly after 1 month.
Okay, sir. And after that she will get periods, sir, to start stimulation, or what happens?
No, she may not get her periods. She may not get. You wait for after 7-8 days. But after 30 days of the second dose, normally the ET is thin, ovaries are now suppressed. Do the E2LH and start.
Okay, sir.
Periods won't come. Periods may not come after the second dose.
So after 1 month of second dose, we should do.
Exactly.
Then should we add OCP?
No, you can add OCP. OCP is not a problem.
Okay.
But I'm just saying that either you add OCP or you don't add. In case you add an OCP, is always she'll get her periods. But the best thing is that in case you don't even get her periods, nothing to worry. Just do her E2LH. Do her endometrium. Endometrium less than 4 millimeter, no dominant follicle, E2 less than 25, LH less than 4. Go ahead, start.
If I haven't done day 2 LH and started with the FET, now if I think on 8th day, if I think to do LH, should I do and assess the patient?
Aarti, on day 2 you are talking about? Day 2 LH?
Yeah, day 2 nahi kara, sir.
नहीं, day 2
रह गया to do LH.
नहीं, day 2 पर ही करना होता है ना आरती. Endometriosis में day 2 LH बहुत हाई आता है.
हाँ सर, PCOS में भी आता है, failed PCOS patient.
आता है ना, तभी तो बोल रहा हूँ ना, तभी डाउन रेगुलेट कर रहे हैं ना. हाँ. तभी तो I'm saying you down regulate. In case it doesn't go less than 4, then you cancel the cycle. See, I am cancelling. See, my cases are at Birla Fertility. I get a lot of the higher end clientele also. I cancel. I wait for 2 months, 3 months. But when I do, I need a pregnancy.
Exactly.
I cancel. See, we can't experiment with the patients. And when E2 LH is high, I stop. Give them 1 more month. They will scold you. They will abuse you. Let them do it. Okay. Finally, they'll get pregnancy, I'm sure. There's more chance.
Okay, so I should give depot.
Yeah, depot. That's what I'm doing now. I've learned my lessons the hard way.
Yeah. After giving the depot, on 21st day of the depot,
yes,
I will start with I will do the LH E2, and then I will start with estrogen.
Correct, Auntie. Correct.
Okay.
I'm totally
thank you, sir.
Thank you. I think we'll stop here. It's already 5 past 10. Got to move on. And anybody else for any final summing up or any other query? Any one of you?
Assalamualaikum, sir. Sharmin, sir.
Hi, how are you, Sharmin? Long time I've not seen you. How are you doing?
Fine, sir. Thank you. You are good, sir.
I'm very good, ma'am. Thank you very much.
Sir, please tell something about embryology part, sir. We do wash several times, but will we go for all ICSI, sir, for endometriosis?
Always. Hemosiderin. They'll have hemosiderin in the OCG complex. So the moment you get an egg, under the microscope, just cut it. just cut it, make it clean immediately after washing it. Put it in bicarbonate based media, and then at as early as possible, just denude and do ICSI.
Okay, sir. Though we will go to denude, but we will cut also.
Remove the, because we have to park them. See, Sharmin, Bangladesh will be having a large number of cases though. We just can't, you don't have so many people that somebody will cut and take for ICSI directly. They have to be parked for around half an hour in the incubator before you finish off, start ICSI, or 1 hour. Just cut them into, remove the cumulus and then keep them in CO2 incubator so that the hemosiderin is not working. That's the point.
Okay, sir. Thank you, sir.
Okay, guys, I think I'll say goodbye to you and thank you so much. My heart is full of gratitude towards all of you for joining us. And this is a big spiritual journey for not only me, you. It's a bondage we are creating so that we all, our gang is always together. We keep meeting, we keep talking. So thank you so much. Next topic is going to be very, very interesting. That's about the male sexual dysfunction. 8 out of 10 men has this problem. So do tune in. This comes with a lot of requests from our ICTians, and please be with me and let's meet after 15 days. Thank you so much. Thank you very much. Dr. Suman is there. If Dr. Suman is there, I'd like her to sum it up. Suman is not here. Thank you so much, guys. See you after 2 weeks. Bye. Take care.
Bye.
Bye.
Thank you.
Bye. 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 Bye.